Okay, I just want to welcome everybody to the session. Thanks very much for joining us in this breakout session. You'll have seen who is on the programme, but I just want to introduce them in a moment. But before I do, just a wee reminder for those who've maybe just joined the conference, there will be a time hopefully for questions and comments at the end of the session. You can either do that either by sending me a direct message using the little speech bubble icon at the bottom of your screen. Send that to me, Sandra Mackay, or if you want to ask in person at the end, just go to reactions and click on the raise hand icon, and then that'll direct my attention to see that you're wishing to ask a question in person. So without much further ado, just want to take this time to introduce our next two speakers. So we have Ros McCallum, who is a speech therapist by profession and who is also a mum to 3 kids, one of whom has cerebral palsy and who has been known to us, great little lad, and who has also been known to Nikki now, and we're going to hear a bit more about your work in a minute. Ros is going to give us her perspective both as a speech therapist and as a mum, her experience of the journey, what that has been like, and with a view to trying to look at how can we best develop pathways and systems to ensure that people with cerebral palsy and their families are supported in the ways that are best to meet their needs. And with her, we've got Nikki Rice, who's joining us from the States, I think.
Boston.
Yes. And Nikki is physio by profession, and she is also the rehab director at the NAPA Center. So I'm not going to say too much more about that. I'm sure they will share that with you in due course. So Ros, I'm just going to hand over to you just now. If you could share your screen, that would be
great. I'll do that now. There we go. There we go. Yeah, so I wanted to talk about our experience with international intensive virtual therapy, which is a bit of a mouthful, but hopefully it'll make sense as we go through it. And as Sandra was saying, I've got Nikki with me today, who is the rehabilitation director at the therapy centre that we've been working with in Boston. So a bit of background to make this make sense for you. Intensive blocks of therapy have been the intervention that's helped our son make the most progress with his development. And we first realised this after attending Cerebral Palsy Scotland. So we attended for a 6-week block when he was about a year old, and we worked with Sandra and we worked with Lee, and we did 2 or 3 sessions a week for 6 weeks. And he learned his first independent movement skill. And this is something that we've been working on for months at home with no success. But doing it in this way, where we went multiple times a week for 6 weeks, this seemed to be the thing that made the difference. And yeah, this just unlocked so much for him, a new world of play and interaction, the fact that he had the ability to move around on his own. So due to this success, we always wondered about the possibility of using this model, doing intermittent blocks of intensive therapy as a thing that worked for him. So when we found out through Instagram, I think it was, that this was a thing, this was possible, and that NAPA Center in Boston offered 3-week intensives, we committed to finding a way of trying it. So then, unfortunately, due to the pandemic, our planned trip to Boston was cancelled. But we were so invested in it going ahead. The plan was 3 weeks of therapy, so an hour of physio a day with Nikki, an hour of occupational therapy for 15 days. So when it couldn't go ahead, we asked, could we try this virtually? And it was a huge success. So I've spent a load of time since reflecting on what made this particular intervention so effective, and why I've felt so much uneasiness about the model of care that we've been receiving in Scotland. So I've kind of broken it down into the impact that the intervention had, why I think it was effective, reflections on the model of care we've been receiving in Scotland, what could the barriers to change be, questions I have, and then opportunities. What can we do next? So that's the kind of structure there. So thinking about our child, and then Nikki can talk to what you guys tend to see in general with children who attend the centre. But for our son, the 3 weeks meant that he made really great functional developmental gains. So he learned to do things that he previously could not do. So, for example, getting from lying on the floor to being able to sit up on his own, which was something that was just completely unattainable for him before. And what we saw as well was it wasn't just things that we directly worked on, that we, repeated and repeated and repeated. We also saw really great progress with skills that we didn't directly work on. Really interestingly, for me as a speech and language therapist, we saw just this real spark with his comprehension of spoken language. So suddenly we saw him responding to simple directions, which was really exciting. I'm trying to think of some other examples. Moving around on his bottom shuffling. Nikki and I didn't directly work on him moving from A to B, but with all the strengthening exercises we did in the 3 weeks, shortly after the 3-week intensive was over, he started to be able to move around on his own by shuffling, which was just huge because he suddenly had autonomous movement. He could move around the house by himself. He could get into everything. And so we saw a really big decrease in frustration because he was able to have more control over his own life and play in different ways and fulfill his curiosity in new ways. And for us, it just felt great because it was so satisfying to have a set of exercises that we were really confident with and that we knew were benefiting him and that we could continue with once the intensive was over. Obviously at a less intensive pace, but we felt really upskilled and we felt really good knowing that we had these things that we could do with him that were going to continue to help him. And it's the other thing that for us has meant that we've had the knowledge of different approaches and equipment for continued success. So we became aware of DMI therapy. We had a virtual session with another physiotherapist who's based in New York, which was really helpful. And we did some fundraising and bought a vibration plate for ongoing strength training, which is proving to be really effective for our small person. An example of how that's been shown to be effective, he's built up the strength that he can now use his walking frame independently, which again is something that we just thought was unattainable for him because he didn't have the strength to move something like that about. But since the beginning of the year, we've been doing weekly strength training on the vibration plate. That's become something that we can do. So I wanted to let Nikki talk about what they would typically see when children come and attend for a 3-week intensive.
Okay, super. So what gains are made? This really is a range. It really depends on the child, where they're at that point in time. But I'd say like in the general picture of things, kids can make 6 to 12 months of progress. And so if you think about the model, a child is receiving, in an intensive model, they're receiving multiple hours of therapy in a day, every day, or 5 days a week for 3 weeks. So that essentially, on average, in a lot of intensive programs that we do, a child might get 3 or 4 hours a day. So a little bit more than the example we just talked about with Ros, but that is equivalent to a year's worth of therapy if a child were attending therapy once a week. So I know, there are even some children who don't quite even get once a week. So that might even be more. So we do see gains that are that great of a time frame made in just those 3 weeks. So how long it would take to make the same progress with a more traditional therapy model, it would take a year to make the gains that we are achieving in a 3-week program. Again, it depends on where the child is at. So I can give some examples of what types of progress children make in after completing an intensive therapy program. So there have been children who come in and can't take any steps by themselves and they leave taking independent steps. That might be 1, 2, that might be 10. We have had children coming in taking 4 steps when they got here and leaving taking 96. So that's like a really great example of an ambulatory child. We have kids like Rue that learn to get up into sitting on their own, or children who aren't able to sit independently, who learn how to master that skill after the 3 weeks. But there are also, times where you have children who need a little bit more support and have a little bit more complexity. And maybe they learn to start weight bearing through an arm a little bit more. Maybe their arm was always up like this and they're starting to learn to put it down. Maybe instead of walking on, the edge of their feet, they're starting to put their feet down flat a little bit more. Head control is huge. So we've got a lot of kids that benefit from this model, who might learn to lift their head up and hold it up for a few seconds by the time that they complete a 3-week intensive. So it really depends on a lot of factors, but leading to the next point, do all children make progress during intensive? I mean, yes, I would say of all the kids I've seen and treated, there might have been 1 or 2 that, I really wasn't sure if there was progress made. And those typically are situations where maybe because they're not in their home environment, that you didn't see the progress. Because often, even when you aren't sure if there's been progress made, to the therapist's eye, you hear from parents that after a few weeks at home, they're starting to do X, Y, and Z that they've never done before. So that's also something that I don't think has been touched on yet. That's really, really great, is the progress continues beyond the intensive, even once you're completed that therapy. So it's very important to continue with carryover at home. But regardless of that, you could stop and the skills continue to improve weeks after weeks. A lot of families report that, by the time that they left here or completed that 3-week intensive, that they actually didn't see the progress until, 2, 3, 4 weeks later. So the gains are maintained, and they're more than maintained. They improve even beyond that. I think mostly because the child becomes more comfortable back in their own environment. Now with virtual intensives, they're already in their home environment, so that might not be the same exact situation. But what's nice about that is they're already comfortable for that intensive bout of therapy. And so hopefully, you see those things happen quicker and you see them later in the day because they're able to translate that more easily. Again, back to the home program, we do require or recommend that families continue with therapy at home. So it's definitely not a one and done. It's not, okay, we did a year's worth of therapy in these 3 weeks, we're good to go. We really encourage carryover because so here's a really important thing for these kids. Why are they making these gains in these 3 weeks? These kids with neurological deficits, they require a lot more repetition for neuroplasticity. And so we need to kind of like rewire and get hundreds of repetition so that we can recreate these neural pathways for them. And that leads me to why the intensive model works. I might be getting ahead of myself because that might be a little bit more in the next slide. But there is so much repetition that these children need. And so to be getting that also in their home environment is great. But regardless, they're getting that repetition to create more neuroplasticity. And these kids need more than just pure strengthening. They need that change in their brain and rewiring, reorganizing. And the intensive model is a really great way to do that. The home programs that are given, it's not, you need to do this every day for a year. We pick up the skills that we think are really foundational and important that we want families to carry over. So gains can be made. They are better maintained and improved if there is carryover. I'd say maybe they last 3 to 6 months if a parent were to encourage any kind of carryover. Feedback that we get from families about their child's progress. I mean, honestly, every family that does an intensive kind of reports how magical it is. We have families that say, you know, we're changing their lives because it's progress that it's really hard to see in a weekly or monthly therapy model, where the child might be getting once a week or once a month or a couple times a month, because it takes so long to see that progress. And then it's like, well, has time just passed? Is that maybe why we're seeing this? And so families are just, you know, given some hope, and they are, you know, given some motivation to do these things at home because they see the changes in that really short period of time. It's definitely a lot of hard work, and I think parents gain a better understanding of how to just interact with their child and handle their child from a motor perspective as well.
Yeah, I think that was really nice that you mentioned like the hope and the motivation, because those were two words that came up when I was thinking this through. Because I think that's one thing that's sometimes hard to come by when you're working the traditional therapy model. It's hard to get that motivation to keep going with exercises when actually you're seeing so little or just such slow progress.
Absolutely, absolutely. And like I said, you know, these, you know yourself, Ros, but these families have so many things to work on.
Yes.
And, you know, it's hard to prioritize as well. But to see, you know, some changes can definitely motivate you to want to continue, you know, X, Y, and Z.
Yeah, I'll skip on to effectiveness because
Great. So this model of care capitalizes on the principles of functional neuroplasticity. So kind of what I just mentioned previously. It is an example of early intervention. There's, you know, use of novel tasks, use of variety of tasks. So an example of this is how can we provide new input to the child so that their brain recognizes this as new and novel? How can we have the same goal but change the task ever so slightly to make it a little different so that it's not just this rote kind of repetition? It's
I thought really a great example of this was the way that you taught Rue to get from lying to sitting. It was just a really clear example because you and Courtney did that in about 10 different ways. You know, sometimes we'd help him at his shoulder. Sometimes we would help him at his pelvis. Sometimes I would sit in front of him. Sometimes I would sit behind him.
Mm-hmm.
Like we did it on the exercise ball. We did it on the floor. You know, like we worked on that one skill, but in so many different ways. So, as you say, it wasn't just this one specific.
Absolutely.
And that had been our experience prior that, you know, this is how you get from lying to sitting, and it wasn't working for him. But then we did it in all these different ways, and we did it so many times that he managed to make that new pathway. Exactly.
That's a really great example. So yeah, so variety is really key in the intensive model, but so isn't repetition, like we spoke about before, is for these neural pathways. These kids in a weekly model are not able to get those hundreds of repetitions, but in, you know, a 3-week model where they're doing several hours in a day, every day, they're getting those repetitions for those neural pathways. Okay, so focused attention to specific tasks. So a core set of exercises was decided on in this study, and then repeated through 3 weeks. And so that's also very similar to what we do is we have goals. We have, you know, transitions to sitting, maybe a tall kneeling, rolling, and we choose a core set of exercises, and then we target it in all these little different ways, or modify it, or change the challenge. So that leads us to high task challenge. These things are not easy. They're not things that children, you know, can access and do quite on their own. So we're giving them these experiences that their brain cannot access on their own. High level of repetition, again, in the study and also what we talked about, focus on reducing support required to do tasks wherever possible. So an example of this might be, standing with a child and you're standing with them by the thighs, and then maybe you're progressively making that support more distal as soon as you can, so that they're not relying on that support and that their brain has to quickly figure out, wow, what do we do now when someone is holding me down here, or making your support lighter, so that you're forcing that child to kind of figure out what to do. It's definitely multidisciplinary. So again, here too, PT and OT, sometimes speech. Comparing that to the intensive model, our program is not just motor. It is, a combination. It's catered towards the specific child. And so it's not, okay, one program fits all. It's what is best for this child? What are the goals of the family that they want to address? Is it feeding? Is it speech? Is it gross motor, fine motor? And often it's good to have all these goals, because often when speech and motor are combined, they kind of go hand in hand, and progress is made in both areas. And Ros said this earlier as well. We didn't do any speech. And after, all of these motor skills have improved, he's starting to verbalize more and cognition. And so that's why, they complement each other so nicely. The stronger you are, the better core you have, the easier it is to sit up. And then maybe your breath support is better, that you can then make some sounds, or improve your articulation, or maybe you're able to swallow better for feeding. So super, super complementary. And then high level of parent training. So this also, we talked about getting parents to feel comfortable with their hands on their own child, and how to encourage things, and know that they can make a difference.
I think this was a really important one for me, because it was a really key difference to therapy locally and to therapy with NAPA Center or with Cerebral Palsy Scotland. So with NAPA and Cerebral Palsy Scotland, we got such a high level of parent training. So it's so hands-on. You get the opportunity to get it wrong, which is how we learn. So you would do it, and then you get feedback on how you're doing it, and you get to try it again. Rather than if someone shows you something once and goes, that would be good for him, and then goes away, then the first time you try it, you're left thinking, oh, am I doing it right? And you can't access, like, oh, actually, no, I remember.
Exactly. And then and then after you're doing it several times, you're starting to realize, oh, I was helping way too much.
Yeah.
And now I can realize what they're able to do. Or if that one day, that one opportunity you had, your child wasn't their typical self, it's really tricky to go off of just that one day. And when you have that repetition, and every day you figure out, all right, what are they able to do and what are they not able to do?
Like overall therapy, this kind of therapy resembled what I would think of as rehabilitation, like in the adult stroke or head injury world, with my background as an SLT. And that just isn't something that we'd experienced from our local therapies. So it got me thinking about our local support and what that looks like. And the story for us was, you're discharged when you're medically well enough from hospital, and then hopefully picked up by your local allied health professionals. So in our case, just physiotherapy, who after some time did refer to speech and language therapy and occupational therapy. However, those were just one-off appointments. So appointments for physio were maximum once weekly, pre-COVID, so that's not a thing anymore. And the other services were one-off for advice, with the instruction to ask for another one-off if required. And the focus was very much on transferring information to the parent for them to support the child. So, and there was no coordinated multidisciplinary care. It was all, each profession doing their own thing. And then once your child's old enough to be in nursery or school, the main focus of therapy switches to supporting your child in their environment. So adapting the nursery environment rather than focusing on improving skills, which feels really early in a child's life to switch the main focus onto environmental adaptation rather than their functional progress. So this model leads to transfer of relevant and helpful information, but that's not equating to the best possible outcomes for the individual child. It's not fitting the criteria in the last slide of effective neurological rehabilitation. It's not capitalising on these principles, these positive principles of neuroplasticity. So yeah, even though the information is it's helpful, it is relevant to your child, but the way that it's being delivered isn't actually leading to any functional gains. So even though individual therapists' knowledge and skills are really high, it's still not translating into progress due to that model of delivery. And it feels like decisions are being made about your child's potential being reached without any access to a trial of intensive therapy. Because that's not a route that's available here, then all decisions are being made without trying that, which feels tough. There's a huge strain on parents to deliver all of their child's therapeutic input. So in our current model, with therapy being advice and parents carrying out the man hours, there's very limited guidance on exactly how much you should be doing, but it's clear that you should be doing it all. And because there's not regular face-to-face therapy contact, exercises can't be highly individualized, because as I know now from working with you on a weekly basis, now that we have an ongoing appointment, exercises need constant tweaking and adjustment to be highly specific and individualized to be effective for the individual. So I feel that the way that we're working at the moment, it's not meeting the NICE guidelines. It's not core multidisciplinary teamwork that's meeting individual needs. It really feels like we're focusing on identifying secondary issues after they come up, rather than focusing on preventing secondary issues. And this is something that really became apparent with the CPIPs thing. I don't know if you know what that is, Nikki. We've got CPIPs in Scotland, so every year children with cerebral palsy get an annual review to check on their spine, hips, ankles, feet. And yeah, it was just really interesting because a therapist is coming in and doing your annual review and checking how you're doing in these respects, but you haven't necessarily seen them in the previous year and there's been no input. So emotionally, I've experienced that as measuring your child's inevitable decline, because there's been no focused input, but yet there's these measurements being made on an annual basis. So it feels like that CPIP service is only half a service. It's like, it's great to be identifying issues, but there's not the other half of it, which is intervention to stop the issues occurring in the first place. This is where I knocked my cup of tea over because I'm getting excited. So thinking about some barriers to change, I think there are very much a set idea about what maximum amount of input looks like. There's not a varied service delivery model for different needs. And we've experienced this overuse of the idea, the young brain's so plastic, by people trying to reassure us, but without offering us any direct moulding activities to help our child's young brain be so plastic, just kind of saying these words to reassure us. But actually our experience has been that if you don't have activities that fits these specific criteria of being novel, and there's a variety of them, and there's high task challenge, there's loads of repetition, very little spontaneous progress is made. It's also really challenging having conversations about accessing private therapy. And there's a real discomfort that arises as having conversations about services not meeting your child's needs. That can be tough. And also at times we felt like we've been placed in a group of kind of dissatisfied middle class parents, or parents lacking in acceptance of their child's limitations because we've been seeking out more therapy. Which I don't think is particularly valid when there's been so little therapeutic input, and we've just been looking for something that's been effective, which we've been fortunate that we've been able to find. So I have some questions. Why in Scotland do we not have a national service for rehabilitation of children with brain injuries, regardless of how they came about that brain injury? And considering the potential for change in this group and the potential to reduce secondary issues, why is there not easy and equitable access to specialist intensive rehabilitation programmes? And why do we lack a cohesive, defined and equitable pathway for care after a child leaves hospital with a brain injury? Obviously, as Nikki talked us through, potential for change varies between individuals. However, without access to trialling intervention that truly capitalises on the principles of neuroplasticity, then how do we know if a person's potential has been reached? And we have a situation that we do have some specialist rehabilitation services for adults in Scotland, like the National Spinal Injuries Unit, but we don't have anything like this for children with brain injuries. And what they're getting is sporadic appointments with generalist community staff, unless they're managing to access something like Cerebral Palsy Scotland, or something abroad like NAPA. Or there's various things people try. They do virtual with smile therapy for kids in Canada. I know people who go to Lanzarote who try things down south in England. So people are having to go elsewhere. So I've tried to treat this as an opportunity to provide feedback and ask the questions covered today to our local allied health professional team in Forth Valley, where we are, the Scottish Paediatric Epilepsy Surgery Service, which is how our son acquired his brain injury, and Dr. Whelan's, the National Medical Advisor at National Services in Scotland, which is where things like epilepsy surgery or the spinal injuries unit sit. They sit under national services because we're quite a small country. So things like these can be commissioned to cover all of Scotland. And following these conversations, I'm more confident than ever that this is a huge gap in service provision. Everyone seems to be in agreement. Dr. Whelans wrote to me, "You're indeed correct in your observations that there's presently a lack of cohesive, defined and equitable pathway in terms of neurological rehabilitation and psychological care for children who have an acquired brain injury." Which leads me on to the fact that the issues highlighted do meet the criteria to commission a new national service. In order for this to be commissioned, we would need more voices. We would need to come together and provide the evidence and experiences to illustrate that this is a very real gap that needs to be filled. So proposals for a new designated specialist service can be submitted by clinicians with the support of their NHS board, or an individual NHS board could do this, or regional planning groups or another national group could compile a proposal. And examples that they give on their website of submission types are services that already exist to provide treatment, but proposers wish to extend. So I feel like this very much fits that example, that we've got Cerebral Palsy Scotland. They offer great services. However, Cerebral Palsy Scotland is a very small charity. It in no way is neurological rehabilitation for the children of Scotland. It's a small charity in one physical location. And new developments involving recently proven techniques. So we've linked some references at the end of the presentation. There's a disappointing amount of research out there backing up intensive therapy, but there is some, and Nikki has pointed me in the direction of some studies that show a positive correlation between intensive therapy and good outcomes for children with cerebral palsy. And then, services that are not currently available in Scotland. So I think it's very much the case. People are traveling to the States, they're traveling to Canada, they're going down to England, they're going down to Lanzarote. That's just some examples I can think of off the top of my head. From, you just need to go on the Cerebral Palsy Scotland, the family Facebook page, and people are they're looking for effective therapy for their children. Or gaps in current provision for which there's an established patient need. And I think it would be very easy to say that there's an established patient need for this. Yes, however, this is not a one-woman job. There would need to be an outline submission, a detailed submission, and a finance, workforce, and delivery plan. So it's my hope that maybe using today as a starting point, I could start finding some people to get together on this and start moving it forward. So I've popped my contact details in Nikki's email there, and the references that I was talking about, showing intensive neurodevelopmental treatment to be a positive thing in children with cerebral palsy, and the link to NAPA Centre's website and national services there. And that's me.
Thank you very much, Ros and Nikki. Just making sure I'm off mute there. Yes, I am. Thanks very much for that presentation and for your time, Nikki, and linking in with us from the States. A lot of what you were saying in terms of your effectiveness slide certainly resonated with a lot of the core principles that we run our centre on in terms of the multidisciplinary, well, we probably work more transdisciplinary team and the repetition and the need for getting families involved in goals that are very much identified by them. I guess one of the things that we're very aware of as a centre for certain is that, you know, we work very I think hard to build up links with the local team. We see that as crucial, because when we then withdraw our input, it's the local team that are usually the people who are there in the longer term. They're the ones who are going to have access to the child in the classroom and perhaps in the respite services, or able to access the funding for pieces of equipment. So we very much see working with local NHS services as and social care services really critical to what we do. I'm not sure how that plays out in terms of NAPA, but that's something I think in terms of when looking to develop services, it very much needs to be done in conjunction with these teams too, which I think you appreciate. I'm just wanting to see if anybody has popped on with any questions. Remember just to click on the little chat button. It looks like a wee speech bubble at the bottom. Pop on with any questions there. I've not seen any come through at the moment, but let me just get my IT. Oh, I'm just seeing my colleague. There we go. Lean, my colleague, has raised her hands. Lean, if you unmute yourself, take the floor.
Hi, Ros, and hi, Nikki, and thank you for the very interesting chat that you just delivered. It's been, I think it was really interesting, and it's raised a lot of sometimes controversial things, I think, and it's really interesting to hear. And I'll explain a little bit about my background. You'll probably hear from my accent that I'm not UK born. I'm from Belgium. I've worked in Belgium for a while and then moved to Scotland. So I have been able to work in very different social care systems and in very, very different setups. And I think the way I was working in Belgium, I was working as a self-employed physiotherapist. So I think maybe a little bit similar to NAPA in the States. And we would see children with cerebral palsy similar on a regular basis, so 4 to 5 days a week, every week, all day long. But the social care system is completely differently set up. It means that you get a reimbursement for a big part of your therapy sessions, but not all. So you still would have to fund yourself a little bit and pay towards it. So that the advantage there is to see them very intensively. The disadvantage is that families will have to pay a little bit themselves. In Scotland, the NHS system is completely differently set up with the advantage of it being all on the NHS, but we're not able to deliver it as intensively as we would like to see. So what we do is indeed short intensive burst, where, as Sandra said, we're trying to work really closely with the local team. And as a therapist, for us, it is often very frustrating to then just, not dismiss, but send them home with the message, try and consolidate on these skills and then get back in touch as soon as you feel like you've hit a barrier and there's a next barrier that you need to jump or negotiate. The question I wanted to ask to Nikki really is, because what we often struggle with is to prove to all these people that are very critical about our services that what we do really works. And I think, Nikki, you will understand where I'm coming from. It's so difficult sometimes to prove in research, in a study, that what we do is actually effective. And it will be really important when you are thinking, Rosalind, down the pathways of going for specialist services and things. And that's what we often, that's a big barrier. And not only for national services, but also to other services out there who sometimes might be a bit more asking questions like, how can you prove that what you're doing is really effective?
Yeah, that's a great point. And that is, I think, a challenge in pediatrics, especially because there is such limited research in pediatrics when it comes to healthcare, right? And I think that's something that we have constantly struggled with getting, even in the United States, getting that acceptance of our model. There is definitely some research out there and evidence to show the intensive model has proven to give these children higher, better gains than a traditional model. A center like us, we also write goals. We do our own assessment on day one. We make goals, and then you can see, notes and summaries to show what that child accomplished in those 3 weeks. But by far, that is probably our biggest barrier, even so in the US. And I think why we've come about is because families have found the funds to figure this out on their own. We still feel like, in the US, you can have private insurance and they will cover some things, but it's still not easy here. I will comment on the, when you think about the funding for a 3-week intensive bout, that's no different than what a parent might be spending for a year of therapy. And so I think that's also just another standpoint that people need to see is yes, it's a lot of money up front in this short bout, but if you do that in this short bout and then the parent can continue doing this at home and prevent deterioration and all these things, then you're not spending any more money than you would in this 3 weeks compared to a year's worth of therapy. At least that's how it is in the US. I can't fully speak to how
Nikki, I'm sorry. I'm going to have to jump in there. I think it's obviously generated a lot of interest and discussion. I'm sorry, the session we're running out, and I don't want to cut you off just without saying thank you to yourself and Ros for sharing that with us, and for your time, and hopefully it'll be interesting to see how this conversation goes. And